Hello and welcome to the Optimal ICAD Courageous Conversations podcast. My name is Matt Thomas and I will be your host for today. And I'm very, very fortunate to be joined by two amazing minds from the addiction, recovery, treatment, psychiatric community. Dr. Judith Landau has got more letters after her name than a dictionary. She's a child, family, community neuropsychiatrist. Her official title is Dr. Judith Landau, MD, DPM, LMFT, CFLE, CIP, CAI, CRS. And she's recognized as a global addiction and trauma pioneer. She's worked across the world with communities and countries, and you'll hear loads more about it in this amazing conversation that's just about to come up with Dr. Constant Mouton, MBCHB, consultant psychiatrist, and he's the clinical head at Triora recovery clinics in the Netherlands and, of course, across Spain. And he studied at the University of Pretoria, the University of Psychiatry in Johannesburg, and the University of South Africa, where he is an FCP Psych SA. And he's also registered as a psychiatrist in the Netherlands as KNMG. So there we go, enough letters to fill a bowl of alphabet soup. Today's podcast is called If You Want to Go Far, Go Together. And this will be a fascinating look into the worlds of Dr. Judith Landau and Dr. Constant Mouton, talking about their stories, their beliefs, their systems, and how they believe we could be moving forward today to generate better prevention, treatment, and continuum of care. So guys, thank you so much for being here. I'm going to hand it over to you.
I'm Constant, and I'm here with my friend and colleague Judith Landau. And we're going to talk about dual disorders or co-occurring disorders, as we like to refer to them, as it is a topic that we both share. So I want to start off with an interesting saying that I've heard recently. It's a Chinese saying that says that the beginning of wisdom is calling things by the right names. And I had to think of Judith when I heard this. In a recent article, you write that we should stop talking about dual disorders and start talking about co-occurring disorders. And that really resonates with me because I always think by calling it dual, we're implying that there are only two disorders. I also don't like the term comorbidity because it focuses on the morbidity instead of what we're doing, the disorders. And then you went a step further and you said co-occurring disorders, actually. So I found that quite interesting, and I think that's kind of the way we should go, because you do a lot of work on the language that we use as well. Maybe you can tell us a little bit more about that.
Certainly, I'd like to start by saying where this first came from for me. I was a very young, very green medical student walking behind the chairman of surgery and his chief resident, or registrar, in English terms, and South African terms, since we share that origin.
Yes.
And the chief registrar turned to the chairman and said, "This is the liver in bed 9. And I had chills. The idea that anybody could be minimized to the name of an organ, not even the name of a disease, but the name of an organ. And I swore that I would never do that myself. And I found when I started working in the addiction field that I was calling people addicts.
Yes, as many people still do.
And in mental health, finding that people were being called schizophrenic or asthmatic or diabetic. And it occurred to me that nobody refers to anybody as a cancer. It would be extremely rude and diminishing. And we don't talk about, there goes the fracture or the pneumonia. So I set off with several colleagues on a campaign to see language as a catalyst for change. And when we refer to people by the name of the disease, we're automatically pathologizing them rather than looking at their inherent resilience and strength. And my entire mission as a professional has been, rather than to look for pathology, to look for resilience. Because we can't build on pathology, we can't build on weakness and illness, but we can build build on everybody's inherent resilience and strength.
Yes. And yet we still hear people talking about addicts and other language things as well. They talk about being clean, which implies that if you're still using, you are dirty. I know you have a lot of other examples of this as well. People still use these terms in the field.
Yeah, and I think that the use of what I regard as derogatory words goes along with the whole concept in addiction that if I've been in recovery for 55 years, if I were to relapse in behavior or substance, I would have to start counting my days all over again. I've been a cancer survivor since my first diagnosis of cancer. I don't start counting days and years again when I have a recurrence of the cancer. I don't blame myself. I don't feel guilty. I don't feel ashamed. By having this concept that a relapse or a recurrence of a chronic recurring illness is something that we should blame ourselves or other people for is anathema in terms of looking for health. The only diseases or illnesses that where we do that are asthma, diabetes, schizophrenia, bipolar disease, and addiction. And those are the ones where the outside world, and unfortunately often treaters within our fields, blame people when they have relapses or recurrences. And until we can take that blame away, we're not going to get rid of the shame, blame, and guilt that our patients and clients feel. And the other part of it is that as long as we do that, we are also in a situation where when one of our colleagues has a problem and has a recurrence or a relapse, we are not all talking about it. I was talking at a treatment center with families, and it was a treatment center for primarily serious mental health issues, but also co-occurring disorders. And one of the mothers talked about her son and how lonely it had been when he developed schizophrenia and was also struggling with addiction. And she said, I've learned that these are not casserole diseases. And we do that with our colleagues. If one of our colleagues breaks a leg or has a serious physical illness, we're all there. Yeah. And everybody is ready to help.
With a casserole.
With a casserole, yes. Or flowers, or a card, exactly. Or a phone call.
Yeah. And
with a relapse or recurrence of their addiction or mental illness, mental health issue, there's a silence.
Nobody.
There's isolation, where we know that being together, being connected, supporting one another, loving one another, regardless of what's going on, is the way to health.
I guess that's the problem with addiction. The person suffering from addiction already experiences guilt. And what I find with the patients with co-occurring disorders, they suffer double. I treat a lot of patients with ADHD, for example, and they tell stories about how they are ashamed of their childhood, having been told that they are lazy or stupid or impossible, or they've experienced that from a very young age, and then later in life they became addicted to something, and then they're almost re-traumatized, I guess, with the language that people use, and also they're also strict on themselves. I found that they are even more strict. Patients are more strict on themselves than the families, which adds to the shame and doesn't help towards the solution. I've recently discussed it with a family that said that they struggle to be empathic in times of relapse. And even though they know that they should be, they still struggle being empathic in those times because it brings up so much of your own emotions and your own stuff, and that makes it difficult to be there for people when they need you the most, I guess.
Right. And I think one of the challenges is that with any of the behavioral disorders, they're regarded as aberrant in our society. And the results of the behavior create all sorts of problems for everybody that drives people apart rather than together.
Together, yes. So you've been the founder and developer, and I guess your life's work has been around, a lot of it around transitional family therapy and ARISE. And one of the things that I love about it is creating that safe space through the language that you use. One of the ground rules when you start working with families is not to use shaming, blaming, and guilt. And we both work in ARISE, but we train people in changing the language. And you see during the course of therapy how the thinking changes. That's the next step. And once that thinking changes, that creates a safe space for families to connect, to reconnect, and experience that warmth to heal in.
Yes, and I think it clearly makes a difference because, I see it sometimes in 12-step meetings where many more of us are talking about being in recovery from addiction rather than identifying as addicts. And the quality of the conversation in meetings like that changes. I think once we have established a difference in the way we address each other, that removes a lot of the blaming and shaming. And then it allows us to put into perspective a discussion about where the addiction started. And the other thing we do to remove the shame, blame, and guilt is look for the underlying dynamics, look for how the addiction started, where was the original trauma, where did the original mental health issues begin, and what has happened with the individual biologically, socially, what's happened in their environment, yes. What are the triggers here and now for both the family and the individual, and what's happening in the environment around them, and what has happened in past generations. And once we can find the origins of the trauma, which often go back not just to this one individual, but generations before, we can start to relieve that sense of personal responsibility. And when we do that and have people realize that what they're struggling with is contextual and goes way beyond them, it gives them a sense of why they are where they are now and allows them to make informed choices for the future, where they can choose the strengths and resources and survival skills of the past in order to pass that on to future generations rather than the shame, blame, and despair.
I find that when I work with families, it's almost like a grief process that they go through once they start looking back and realizing where the addiction or even the physical health issues come from. They first start off often being victims of it, and then by changing the language and the way they think about it, it becomes a factor of strength and resilience, and that is where the healing starts.
Absolutely. And we often do formal, as you know, formal grief resolution work. And thinking about one particular family where the young woman was 19, severely addicted to benzodiazepines. She had started her training as a nurse and failed out, and then attempted suicide seriously 4 times, and nearly died all 4 times. And we were called into the psychiatric unit because they had given her electroconvulsive therapy, and that hadn't dislodged the depression. When we had a family meeting and asked about, first of all, removed the blame and shame, she was sitting like a lump, just feeling absolutely awful, and her sisters were furious with her because she was destroying family life and not being an attentive aunt to her new little nephew. And we started asking about losses and past generations, and no, there were none. And when we pushed a little bit, asking Mother whether she'd ever lost anybody, and she said, well, my father died 10 years ago, and my mother is still walking the halls all night weeping and wailing. And a little tear appeared in one of her eyes. And then she said, and then 2 years ago, which is exactly when her daughter started being depressed and using benzodiazepines, which was also as she was leaving home and going into nursing school, 2 years ago, I heard a gunshot, and my best friend who lived next door was killed by her son on the roof of her house. And by now she's just more tears. And I said, anyone else? Well, I had a stillborn baby, and when they asked whether I wanted the baby to bury, I said, no, just take him away. And I don't know where he's buried. I don't know what happened. Was he just in an incinerator? And now she's sobbing freely.
Wow.
And then she says, and when my nephew was born, he had a problem with a kidney. He's fine now, but we thought he'd die. And she's just sobbing and sobbing, and the two sisters are now sobbing. And I turned to the father, who was sitting exactly like his daughter, absolutely stoic, not an expression. He put his hand in his jacket and pulled out a yellowed piece of newspaper and handed it to me. And I said, before you give it to me, could you read it to the family? They didn't know what he had, that nobody knew. He was the sole survivor of his platoon in the war. And then his daughter started to cry. And we had a memorial celebration of all those who had gone before, including all his colleagues, and the grandfather and the entire family came with songs and poems and stories. And she went back to nursing school. She's been fine ever since. But that grief had to be resolved for them to be freed up to move on.
Yeah, and this is grief within the family that was not spoken out. It was not told ever, which is an interesting fact, because people always think that they tell stories within the family. But I find this as well. When you start with families, usually they have no stories, or they don't see it as a trauma, I guess. Or people hold the stories on their own and they don't share the stories. And by sharing the stories, they start learning to grieve for what happened in the family. And that's also part of the healing process then for them.
Right. So that combination of secrecy and unresolved grief is one of the major reasons that we see addiction, that underlying trauma or loss that's never been dealt with.
Yes.
And if we wait for it to be dealt with in the natural passage of time, it takes 3 to 5 generations. So we can't afford to wait. We have to work with our families, and not just with the individuals, so that we can have them talk about those stories and share them. And if we want to talk about prevention, we need to encourage families to share their stories and to be talking to the young ones, not just about the good stuff, but also about the survival stories, the things they've overcome.
Yes. So you said we were talking about families just now, and I know you say that it takes 5 of us as professionals to replace 1 family member.
Mm-hmm.
I
know it's very humbling to think that it takes 5 professionals to replace 1 family member. But it still scares me that there are so many treaters and treatment centers who work entirely alone. And that's fine. The individual work is helpful, but it needs to be accompanied by family relational work, which can always be done by someone else if you're not specifically a family therapist. But it has to be done if we want long-term healing.
Yes. Yeah, they say that. Well, I guess it's coming from the African proverb of Ubuntu. Absolutely. Like, I am because we are. We are not alone here, and there's a reason why we are not alone on Earth. We are here to help each other, and also to heal. And what I also like about the work that you do is it's not only about families, but you also make it bigger into communities. We should also involve communities in the healing. If we expand the network, the intervention network or the healing network, which way you want to call it, we need to also involve communities to also work through their loss, because what we see in the world with all the disasters and things that are happening, we see a lot of trauma within communities, which translates into family trauma and individual trauma and addiction in the end.
Yes. Well, and the family is the unit of healing and survival in communities. And if we can mobilize individuals and families in the community, we can really change the way communities respond to both local and mass disaster. We can change the way that if there's an epidemic of adolescent suicide and we can mobilize the community, we are able to prevent that epidemic from spreading further. And in the same way with, for example, the fires that have just been destroying California, or the random violence that we're seeing so much more of. If communities are collaborating and connected, and the families within them are working together, they're able to withstand an enormous amount of trauma and gain from challenging times. Because we can, resilience really is that capacity to deal with loss, to deal with challenging events, to deal with trauma, and to come out at the other end with increased connectedness and strength.
Yes.
And survival skills. But it doesn't happen without very careful planning, without really working to connect people within those communities, because we've lost a lot of that connection. And that's where our strength and our resilience lies.
Yeah, you always say connection is protection.
Absolutely.
I fully agree with that. Let's talk about strength in numbers. We've spoken about the help within the family. Within the professional community as well, I believe that that's also a place where we should have strength in numbers. Most treatment centers, most people treating tend to work within multidisciplinary teams. Some people also tend to work alone, but I think also within our professional communities, working within groups also make us stronger.
Absolutely.
We always work in, I think everybody knows the traditional multidisciplinary teams with a psychiatrist and a psychologist and a counselor and a social worker.
And an activities therapist and a music therapist and a horticultural therapist and an art therapist.
Yes. Those are the typical teams that we use. But we tend to forget to use the family as part of that team, and the person in crisis or the person in need of help, the patient, if you want to call them that, also as part of the team. And I think that's an important thing we shouldn't forget when working with people suffering from addiction.
Yes. And unfortunately, that's the family and the person of concern are often left out.
Yes.
And our strength is that we have the knowledge and the training and the expertise in whatever, whether it's mental health or addiction or physical health or a combination. We have that educational piece and the training and the experience, but we don't come anywhere near the individual, the person of concern and the family in terms of their knowledge about themselves. So leaving them out is a huge gap in treatment. And unfortunately, there are still many practitioners working independently outside of treatment settings where they don't work collaboratively. And I know you and I both feel very strongly about individual practitioners developing their collaborative teams as well as including the family. And I think we lose so much when we don't do that, because we lose the insight about what are the family values, strengths, themes, what are their stories, what are the things they believe in that might or might not be important and that we might need to include in the way that we work. We do think, and I think with the global community at this stage, that there are families from so many cultures moving all over the globe, and practitioners who don't bother to ask how they live, what their values are, how they communicate, what they really feel should be happening, what would have happened traditionally in their old country, and try to work with them from the perspective of their own culture, and it doesn't work. And that sense of helplessness, they don't ask the questions. They don't bring the family in to help educate them about the culture or about the history of the disease.
Yeah, and it doesn't have to be an obstacle. I find it's some of the most valuable information pieces I get when treating people is by going to their homes and listening.
Mm-hmm. I had a situation yesterday at the conference that we're both attending, and this young woman who is studying to be a psychologist asked me what she should be doing with a family, and family was East Indian, and the young woman is struggling with very serious depression, some self-harm, and behavioral compulsion, and also drinking heavily. And she asked what she should do because her colleague who she was working with had a meeting with the mother, the father, and the daughter, and nothing had shifted. So she did family work. She had one session with the parents and the the young woman. And I said, well, if the family's East Indian, do you know where the power lies? No. I said, well, this is a matrilocal, matriarchal family system where if you're not working with the mother-in-law, who is the person in charge of the family, you're not going to get anywhere with this young woman. And she was stunned. It hadn't occurred to her that the cultural background was going to make a difference in the way she should be working. And she's a very bright young woman, and I know is going to be a wonderful psychologist because she got really excited and was ready to start learning more. But unfortunately, a lot of the educational programs do not include much work on working cross-culturally. And at this time in the global community, if we don't understand the differences in cultures, and it's not just macro culture like that, it's the microculture of each family. We have to learn from the families.
Yeah, I find people are often paralyzed by the idea of getting to know all cultures and I have to know everything. And actually, it's not necessary as well. I mean, basic knowledge about working interculturally is enough often. And it's
learning
about
to ask questions.
And listen, yes, listen. I mean, that's half of what we do, is go and listen to the family. And also visiting families within their homes is so valuable to really know what's going on. And then a lot of the things that we learn is not so much in the conversation, but what you observe in the room, on the way they interact.
Constant, you were telling me a little while ago about a woman from Morocco you treated, and I wonder if people would be interested in that.
Yes, so it's a patient of mine that's originally from Morocco, and we treated her for addiction and co-occurring ADHD. And the therapy was going well, but we didn't progress into getting the family on board. And we were wondering what was going on. So eventually we got to a point where we had the whole family on board. And we realized within the therapy that the father was also suffering from ADHD, but nobody ever spoke about it. And then in individual therapy, she started to speak about it and tried to confront the father, which led to almost a reveal within the family of this big secret that they've been keeping, of him having been diagnosed as ADHD, but being ashamed of the diagnosis. So he didn't suffer from addiction, but from ADHD, but he was also feeling the shame of the diagnosis of ADHD. So we spoke a little bit about shame and blame. And then there was still a blockage in this family to progress further. And what actually happened is her grandfather passed away in Morocco, And her father went to Morocco to bury her grandfather, came back and told her that the grandfather was buried and passed away, and that she's not allowed to grieve. And this was very interesting because he never learned to grieve as well. There's a long history of people within the family not being allowed culturally to grieve in the way that she wanted or she needed to grieve. So we also went through a similar process to the case that you just discussed, to go through the grief for her. But we had to do that individually because the family was absolutely not open to let her grieve with the family. And I was wondering what your thoughts were on that.
I love that you were flexible and able to do that individually, because I think sometimes people think that when we're talking about working with families, that everybody in the family has to be there at once. And often it's important culturally to be able to divide them, to do certain pieces with different members and different subgroups. For example, working with families from with an Islamic background, it's really important to separate the genders when one's talking about certain subjects. And I think the fact that you did this so creatively and worked towards your goal of dealing with grief resolution with all of them and doing it in parallel is what allowed you to get through that piece where they were stuck in order to move on to be able to get to family connectedness. You might never have got there without allowing yourself to do things that might have felt a little bit outside of the norm.
Yes.
And I think that's one of the things that we should never forget, our own creativity. That as therapists, we may follow the process of a model, of a philosophy, of a theory. But what we bring to the content has to be a combination of ours and the family's. Otherwise, why do we gain experience? We could all just become automatons following a process automatically. So I love that you did that.
Yeah, it's
and
really...
it's so much the theme of grief and trauma and loss that underlies first breaks in mental health issues, first breaks with addiction, and even, we know that in serious emotional trauma leads to heart disease and lung disease, and exacerbations of all sorts of other physical illnesses. And I think having that open view that ideally we want as many members of the family and support system and family of choice and friendship and neighborhood involved, how we involve them and when we involve them, it calls for the skill of the therapist. And that's a beautiful example that you just shared.
Thank you. Yeah, another way in which we should be flexible, I guess, is what do we call a family? I think we kind of get stuck in the normative family structures in our heads. And
the normative is according to our own culture.
Exactly. So that's exactly it. And we forget that there's a lot of immigration, there's a lot of alternative family constellations that we have to look at as well, and even involve friends or whoever the person sees as a family. That could be their family. It happens so often that we have families that are too small, actually, or I don't want to say too small, that are, I guess, marginalized and alone in a new country.
Without the support system.
Without the support system. And then you have to be very creative as well.
Remembering that we need at least 4 people to be able to bring about change. And
4 family members.
4 family members, and those family members can be family of choice, they can be neighbors, they can be friends. So 4 members of what we call the natural support system. If we do the distinction between natural and artificial or ancillary, natural support system are the people that we connect with on an everyday basis. our friends. It may be the neighborhood shop, the neighborhood traffic cop who's escorting the kids across the road, the teachers, the sports people, our primary care providers. And the ancillary system is all of us as professionals and the specialty hospitals and doctors and so on. And when we see people who have a huge number of the professional system involved, we know that they're not going to get healthy unless we help them really build a natural support system.
Yeah. Also knowing that it takes 5 of us.
That's right, to
replace one family member.
Yes, exactly.
I like to think of it that way. If I see big healthcare teams struggling to treat a patient, to turn that around and find family members. Because part of resilience as well, and the work that I guess we do in transitional family therapy as well, is teaching the family to be resilient.
Helping them access their inherent resilience.
Exactly, and that helps people in the future to not need us. Mm-hmm. And that's what's great about working on resilience rather than shame, blame, and guilt.
Exactly.
To work on the inherent resilience within the family and the unit.
Yes, because really where people get overwhelmed by stress is when there's an imbalance between the stresses and the resources. And so when we think about all of us go through major times of stress, every time we deal with a life change, a transition, it can be a celebration like the birth of a new baby, it could be a promotion at work, it could be something sad like a loss. Each of those brings with it a certain number of tasks. And if we can add up that number of tasks and the number of resources, and there's an imbalance, we're going to see stress, and we're going to see stress-related illnesses and relapses or first breaks. So helping the family understand that really makes a difference. And it also explains why 3 or more transitions within a relational system, family, friends, close people at work, 3 or more transitions in a short space of time throw people off balance and somebody develops symptoms. And those symptoms slow down the change. People come in to help because there are problems. And it happens naturally that we start to find a way to resolve that, but we can actually take charge and know we're going through this many transitions. Our clients are going through this many transitions. Let's add up the resources. Let's help them find additional resources so that when this happens to them again, they know how to deal with it. Yes. And they don't have to be symptomatic or relapse or develop other problems.
Yeah. One tool that I like to use in helping families to access their resilience is the transitional field map. And, you developed it, so I don't have to tell you about it, but just for the listeners, it's a wonderful tool to look at different levels at which you can access resilience. So we start with the individual. What can you do as the individual yourself?
Biologically and psychologically.
Exactly, and then you move on through the different levels because you're not alone. So maybe you can elaborate a little bit on that.
And then we look at the social system, which includes family and natural support system. And then there are times where we have to look at the artificial or ancillary or professional level and mobilize that collaborative team. And all of that's embedded in our cultural system and our natural world. Has there been an earthquake, a flood, a fire? What's going on with the other things in the cultural system, the language, the way in which people relate, the political system, all of which have an influence, and what's happening in the town around them. I think about working in a city where there was a large company that would have major layoffs of people from work. And we would listen to the news in the morning and know that if they announced that they were laying off people, that our emergency room, our addiction clinic, our family clinic, and the medical clinics would be full of patients that day. and over the next week, because of the reverberation, not only with the people who were laid off, but everybody else in the family.
Yeah. And I guess this paralyzes people as well. Like such a big transition paralyzes the family and the individual to see the resilience that they still have, and all the factors that they can still access.
Yeah. And I think sometimes, we would have to work with the people training to be family docs and primary care providers, because they would see these minor illnesses and not even look to see what was going on in the family or the environment or the workplace that led to people developing minor illnesses. And we now know that over 90% of people presenting to a primary care provider with repeatedly, the frequent flyers with minor illnesses, are living with somebody with either a mental health issue or addiction or a chronic medical disease. And the importance of looking at the context. The transitional field map's really useful to make sure that we really look at every level. Yeah. It also helps when we draw it for families and have them put in the number of people at each level. And if we see a huge number in the professional level and nobody in their natural support system, we know where we've got to work.
Exactly. Yeah. I actually print it out and give it to families
That's
to fill
great.
in as homework.
Yes, wonderful.
And then you have a visual aid as well to help you to see what's going on.
Yeah, there are a lot of transitional family therapy tools that really help families. And I think most of what we develop is for the families and the individuals we work with. It may be useful to clinicians, but it's ultimately all the work we do, all the research we do is to help make the way we work more accessible and better for the individuals and families.
So we've been busy at Triora to do something very exciting, and that is incorporating a RISE model into our current treatment model. And I just want to talk about that a little bit. We've had the training 2 months ago, and we are slowly but surely integrating it into everything we do. But a very concrete thing that we have done is to start following up patients in their own environment after the treatment. And this has been really, really exciting work to do, but also exciting to see the work that the families have done and how that translates into the recovery of the individual, the person of concern, as we call it in RISE terms. We've had really, really so far great success in involving the family, involving the network, and accessing their resilience. And it's really been amazing, the feedback that we've been getting from the patients themselves, that it was such almost an easy transition going home, where that's usually a very scary time in treatment, just after being treated in a treatment facility, having done a lot of individual work, and then all of a sudden kind of going back home, and you have to deal with everything, and your environment hasn't changed. So what we've been seeing with the work we've been doing is by helping the environment to adapt while the person of concern is doing therapy, actually gives so far much better results than just treating the individual alone.
I think one of the things that I've been really excited about is the way in which your entire team has accepted the philosophy, the RISE comprehensive care philosophy of resilience, and seeing that comprehensive continuum of care with collaboration being seamless from during treatment into their home life. And it's also really exciting watching your individuals and families get healthy in parallel, rather than what used to happen with individuals returning to an unchanged system and relapsing. And also it's just exciting watching whole systems get healthy together. It's and with joy. Like very much what we've seen in other programs, where when there's been independent evaluation later, that both individuals and family members are happy about it and feel good about themselves.
Yes.
So it's wonderful seeing the work that you're doing at Triora.
Yes, it's very exciting. And it's also exciting to see how that's also leading to us including other professionals within our healthcare team. We're working much more with recovery coaches, with interventionists. I want to just talk a little bit about the ARISE protocol because we've incorporated the comprehensive care side of it into the treatment center, which is actually great for aftercare as a continuum of what we've been doing within the clinic. But there's also the intervention model is also part of ARISE, and you actually call it comprehensive care with intervention, which I think is a very great name for it as well, because that's exactly where it is. So if there is a risk of relapse or a relapse happens, it happens in a completely different way than people are used to because you can escalate through level 1 to 3, but you can also, the family is assisted in dealing with the relapse in a positive, warm, welcoming, a way without using shame, blame, and guilt. So it's actually another tool that the family gets. It's maybe the biggest and most important tool that they get, is how to deal with relapses.
Yes, and I think the staff as well, because once you've got the family network involved, they're able to work with you to prevent people signing out against clinical or medical advice.
Yes.
So, yes. I know with our most of our ARISE certified programs, the rate of signing out against advice drops way down to 1 to 2%. So that's exciting. And then that capacity for family members to pick up not just on the triggers that might be putting their loved one at risk, but also on their own triggers. And it's fun watching those in parallel because I think sometimes we forget that the family has triggers too. And when we have them upset about something or going back into old behavior, I love that we have the individual who's been seen as the problem becoming a member of that healthy network and able to say, wait a minute, mom or dad or wife or husband, what you're doing is getting back into some old behavior that's triggering me.
Yes,
that they're all part of the solution instead of part of a problem.
Yes. Yeah. And the person of concern actually becomes, in a way, the wise person in the room because they've been through therapy. One of the things that I've seen lately that really excites me is to see how the language of the family changes, not by what we're doing as professionals, but by what the person of concern is doing. Yes. When you hear a relative back saying something like, yes, we've been doing this or that, but we work step by step, not everything at once. And I know this is something we teach patients at Triora. Right. And I know where it comes from. It's not from us. It's not from the professionals. It's from the person of concern themselves.
That's wonderful. And they're also holding their family members accountable. And I know we don't use the terms enabling and overprotecting and enmeshment. We can use them clinically, but we never use them with families because we want them to understand the underlying dynamics of finding other ways to love intensively and to deal with their fear of loss. And you're right, the individuals, the people of concern will hold their family members accountable. Wait a minute, can you find another way to express that so that I don't feel smothered or I don't feel overprotected? Yeah. Can you tell me instead in a different way?
Yeah. Or please stop, that was blaming language.
Yes.
We don't do that anymore. Right. I've heard recently. That's really great, and that really gives the family a more positive experience of therapy as well.
Mm-hmm. Well, because they've absorbed a philosophy that is non-pathological, and they know that they have the capacity to live healthy lives, which is a huge shift.
Which is actually what we're all working towards, is recovery. And health.
Exactly.
Yes.
And it's interesting, sometimes I find that it's easier to have the clients and the families make that shift than it is to see the professionals make that shift. And what I love about the Triora team is they are making that shift beautifully.
Yes.
Because it has to be there or the families aren't going to absorb it.
Yes.
So one of the things that really got me started in this particular protocol of transitional family therapy was noticing that less than 3% of people struggling with addiction get the treatment they need, whether it's residential, outpatient, intensive outpatient, almost anywhere in the world. And that a lot of people see treatment as needing to be residential, where in fact, in most countries, residential treatment is only used in about 12 to 15% of cases. And there are a number of outpatient options available, which are a lot cheaper. The challenge to me was that there are very few professionals, if we think about them only managing 3% of the cases. So we set about trying to develop a very clear protocol that would be, first of all, be accessible to large groups of people and that could be provided by people without special mental health and addiction training. So in our original study, we trained people. Some of them were just out of high school, and this was in the United States, where they were just out of high school and working as volunteers in a volunteer association, all the way through to psychiatrists, psychologists, family therapists, addiction counselors, and so on. And if they learned the protocol thoroughly, they all did equally well in getting people into treatment and keeping them there through continuing care, continuing comprehensive care. And it was very humbling, but it also happens because one of the things that some of the government organizations in various countries believe is that you have to have a protocol with not just a process, but the content absolutely clear before you can replicate it in other situations. What we did in our research, and many others have done, is discover that what's replicable is the process. The content has to belong to the people acting on it and the individual clients and families using it, or communities. And then you can use it in many different places. And it's very easy to teach. We're now moving into training trainers, because that way it can spread much more easily and be much more affordable. And when one has trainees and you're working with grassroots people in the community as your family and community links, one then has people able to deliver services and to do the prevention work across large quantities of people. When we worked with a whole community, we worked across all of Argentina 25 years ago now. And with working through family and community links, within 2 years, we had a 400% increase in the number of adolescents and young adults struggling with addiction being brought into treatment. And we worked across the whole of Argentina. The evaluation was done only in Buenos Aires province, which is 12 million people. And the interventionists were paraprofessionals, community members, working as links with us as facilitators, getting them trained and then moving out. And at the 15-year evaluation, 93% of the community projects that had started were still in action, and they're now doing a 25-year follow-up. And that's with members of the community delivering the intervention and the services. So it can be done. It can be done extremely cost-effectively. And unfortunately, in the addiction field, intervention has been seen as something only for the wealthy. And for me, coming out of a socialized medical health system in South Africa and knowing that there is no difference, addiction doesn't choose the wealthy. It doesn't choose those of prominence. Addiction is a disease that affects everybody. And our responsibility is to make sure that when we're doing prevention and treatment, we can reach everyone. So there are a number of blocks everywhere in the world. Given that only 3% of people get into treatment, we ought to be having much more money allocated to the efforts to get people engaged in treatment and to get them sustained in treatment. It's no good just to drop them at the door of a treatment center and hope that they're going to be healthy, because we know from outcome studies that long-term health is dependent on completing treatment and involvement of the family and natural support system. It's not just getting someone to the door. And unfortunately, health insurance companies and even in systems like the UK are not covering that front end, and they're not covering the continuum of comprehensive care. And so we all need to become advocates, because it's not good enough for us to be highly successful with 3% of those who need us. And the US is beginning to move. There are 3 states now that will reimburse for those front-end services, but it's still an enormous struggle. The money for prevention in most countries is way below the money for treatment. There are a few systems like Kosovo where the comprehensive care for all co-occurring disorders is delivered at every level of the community. I had the privilege of working with them during and after the war, and they developed an incredible system of public health and for health, mental health, and addiction delivery, where there are decentralized health houses in every community, and only if being at a health house doesn't work do they go up to a clinic that has nursing and more skilled care, and only if that isn't sufficient do they go to a specialty hospital. And within 1 year, and they're not allowed to come to a health house or any of the services without a family member. So within 1 year, people with schizophrenia had a 98% compliance rate of attendance and taking medication because family members were involved. And it's become a model system. And unfortunately, in our wealthier, larger countries, this is not happening. And we're still doing individualized treatment and not relying on the natural support system, who can help us work much more efficiently, much more effectively, and much more cheaply. And that's the true answer to cost effectiveness, is working together. We're back to Ubuntu, and there's another African saying.
I'm thinking of that. I don't know if you're thinking of the same one, but I'm thinking of the one, if you want to go fast, go alone. If you want to go far, go together. I don't know if you were thinking of that one.
Which is the essence of Ubuntu.
This is
we need to rely on one another to be effective. Connectedness and trust in our inherent resilience is what makes us strong. And wisdom is health and education and togetherness.
You've been listening to the Optimal ICAD Courageous Conversations podcast. Thank you for listening. And if you're interested in hearing more about us, visit www.icaad.com. That's www.icaad.com, or click in the link in the show notes below this podcast. Thank you.